another flashback. I would ask Dr. Ahmed Farid, please. I think you will give us some echo aspects of the flashback.
Good evening, everybody. Thank you, Professor Said, for inviting me for this event. And I consider this session, I consider this session as a healthy snack between all this high sugar talks and lipid-rich talks. And if someone knows me, I'm an imaging guy, so my case will be about imaging. And actually, this case I have done like 7 years ago, but it teach me a big lesson, so I try to share it with you. She's a 59 years old female with long-standing history of hypertension. She was diagnosed as having severe pulmonary hypertension 5 years ago based on echocardiography. She was investigated, she has an exertional dyspnea, and she did an echocardiography that revealed severe pulmonary hypertension. But no right heart cath was done for her. Over the past 5 years, she done multiple echocardiographies that revealed and confirmed the presence of severe pulmonary hypertension with a pulmonary artery systolic pressure ranging from 65 to 90 millimeter mercury. She is currently on sildenafil, loop diuretics, and ARBs for hypertension. On physical examination, the patient blood pressure was controlled, 120/80. His heart rate is 80 beats per minute and regular. She had mild bilateral pitting-lower limb edema, and she has a grade 3/4 holosystolic murmur at the left sternal border and apex without additional pathological findings. She was referred for me for assessment of the pulmonary systolic pressure on her current treatment. And this is her echocardiography. You can see this is the parasternal long axis view. She had some calcification of the aortic valve and mild to moderate aortic regurgitation. On the left side, this is the RV inflow. You can see there is a significant tricuspid regurgitation. And on the right panel, you can see the short axis view at the base of the heart was also revealing significant tricuspid regurgitation. You can see here that the LV function on the right side is preserved with no significant wall motion abnormalities. And on the left side, you can see the RV inflow view of the tricuspid, and you can see the tricuspid is not morphologically disfigured, though the amount of tricuspid regurg you had seen. As you can see here, that the LV dimensions and function is normal. And this is the apical four-chamber view. You can see from here that there is some aortic regurgitation and significant tricuspid regurgitation. You can see also that the right ventricle is a little bit dilated. And this is the continuous wave Doppler over the tricuspid valve. You can see here, it's very high gradient over the tricuspid. Under normal conditions, you would stop here and see, and you can say this is a severe pulmonary hypertension. But what draws my attention is the upper arm of this wave. I don't know if you can see the pointer or not. Yes, this segment. The tricuspid regurg should be only systolic component. It's below the line. Why there is something above? So this raised my attention to take some off-axis view with additional color. Look at that. Can you see anything abnormal here? You can see there is a funny flow that's coming, something like a VSD. There's abnormal flow here. Yes, there is a VSD. There's a connection between the LV, but where it is going? It's going to the right ventricle or to the right atrium? Actually, it's going to the right atrium because it is below the tricuspid valve. You can see this image. It's very clear. So this is by definition a Gerbudi VSD. And here, you can actually miss this very easily as the previous operators has did, because the continuous wave of the high velocity jet through the left ventricle and right atrium detect that was initially misinterpreted as the high velocity TR jet. And the pulmonary artery pressure was calculated based on this trace. And note also, it is directed toward the right atrium, like the tricuspid regurgitation, so it could be easily mistaken. Now, I am back to study the patient from the beginning again with some off-axis view to confirm our finding. And you can see here, there is some sort of connection between the left ventricle and the right atrium. And when I put the continuous wave of this off-axis view, you can see a bimodal high-velocity jet coincides with the direction of the jet from the VSD is going perpendicular to the continuous wave Doppler signal. And when you're moving a little bit outward, you can see there is a tricuspid regurgitation velocity. That's the classic tricuspid regurgitation parabolic flow that's going below the line. And there is some sort of mild to moderate pulmonary hypertension. And this is the subcostal view. It shows it's very clear that this is a jet body defect with a connection between the left atrium, the left ventricle, and the right atrium, and with a peak systolic velocity crossing the 5.2, almost 100 millimeter mercury. At that point, I was a little bit hesitant to diagnose a jet body defect in a 59-year-old female because she didn't have history of any previous surgeries. She didn't have history of any prolonged fever, coincides with infective endocarditis. She doesn't have any chest trauma. So you are left with a jet body defect that's mostly a congenital that had been discovered when the patient reached 60 years old. So I ordered the CMR. The CMR here has two benefits or two rules for me, is to confirm the diagnosis and to calculate the QP and QS to see if we should close this or not. And actually, the CMR confirmed the finding that this is a jet body defect. And the QP over QS was 1.6. Then it should be closed. And it confirmed that the right ventricle is dilated with preserved systolic function, and the calculated right ventricular ejection fraction was 51%. As we all know that the jet body defect is a communication between the left ventricle and right atrium, and it's usually congenital, but it may be acquired like cases of infective endocarditis, myocardial infarction, chest trauma, or previous cardiac surgery. And the main pitfall in the diagnosis is to be mistaken as tricuspid regurgitation and pulmonary hypertension, like what happened with our case. And the differentiation is done by meticulous echocardiography or multimodality imaging, and the treatment is by cardiac surgery if shunt is significant. So what I have learned from this case, the first thing that I have learned from this case, don't take previous diagnosis for granted. This patient had like 6 previous echocardiographies that performed or confirmed the presence of severe pulmonary hypertension. The second learning point is the color erasing site. The shape of the continuous wave Doppler and the frame-by-frame display help detecting defects. And take your time doing the study. If you had any suspicions, please take your time with the patient. 5 or 10 minutes extra of your time may mean the life of the patient. Please take your time during the study. And my last learning point here, be generous with other imaging modalities. If you have doubt, please send the patient for a higher other modality, especially when indicated, and especially if you are dealing with a rare condition such as Gerbudy defect. And by the way, this case had been accepted and presented in EuroEcho 2017 by me in Barcelona. And thank you for your time.
Thank you, Dr. Mohammed. I have a comment, of course. Dr. Ahmed Farid, Dr. Farid. I have a comment, of course. I would add another point to the take-home message that you don't diagnose pulmonary hypertension only with TR.
Yes.
The way the interventricular septum looks and the way the RV looks really shows that it's not a pulmonary hypertension.
Yes.
So you don't take just the measurement because it can be easily mixed. Even if you have a mid-cavity RV obstruction, you might diagnose as pulmonary hypertension. So it's not the story of a TR only.
Exactly.
And it's not enough to diagnose a patient with pulmonary hypertension if he has only tricuspid regurg. You have to exhaust your methods with the echo in order to write down that this patient has pulmonary hypertension. And you have to study too the pulmonary regurg to measure the mean pulmonary artery pressure.
Yes.
In order to justify the study. The other thing, the Gerbudy defect is not as rare as written in the literature. Actually, at Ain Shams, we already had congenital Gerbudy like last year, like 6-7 cases, and we closed successfully 4 cases by catheter. This is uncommon, and we are publishing the data. but now it is possible with the newly developed devices to close the gerbody defect, but it has to be larger than this. This is a small one. It will not, it cannot be cannulated
Yes.
from other
I think
side.
because if it is small, the patient tolerated this until they reach
Yes,
this
yes,
age.
it's a small
Yes.
one. This, the diameter of the right-sided opening is less than 3 millimeters, so it's not that big.
Yes.
As I see. Thank you, Dr. Ahmed.
Thank you,
Very
Fatima.
interesting.
Thank
case.
you.
Also, the presentation would be not very early. You should have suspicion all the time when you have unexplained pulmonary hypertension.
Yes. Actually, Dr. Yes said that the pulmonary hypertension is really an underdiagnosed or under-investigated diagnosis that we face every time with echocardiography. You just have a TR and the elevated pulmonary artery pressure and a major pulmonary hypertension, and that's it. You should investigate each case of pulmonary hypertension, including if you didn't find a cause, but like the ASD, hidden ASD, sinus venosus, ASD, shunts, you should investigate it by the right heart cath to see if this arterial even or other causes. This is very underdiagnosed and under-investigated diagnosis in our practice.
Diagnosis of primary without getting
Yes.
too much data of the patient
Yes.
would be, it's a secondary one, yeah.
I like your statement about that and most of time we find in the conclusion of a lot of reports that pulmonary hypertension without searching for the cause. It is vitally important to search for the cause before you are reporting your final report for such a pulmonary hypertension. Another important, which is also practical here, and I see young faces here in the hall, that when you have a case which is frequently examined before, you have also to examine it on a perfect machine, because sometimes the machine will deceive you again and again.
Yes.
So if you have a case examined before frequently, as you mentioned, you have to have a good machine before you examine it. Again and again, thank you for these very important flashbacks for the echo cases.